syndrome is real and has been puzzling the dental and medical professions for decades. This is the TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMD Demystified podcast.
Hi, everybody. Hello. It's Saturday noon, and we are here for the next episode of TMD Demystified live stream. I am Tony Urbanek. Today, I will be discussing the topic of temporomandibular joint disorder and ear infections. Ear infections, ear pain, ear aches, and TMD. To remind everyone, if you're new to the program, this program is designed for both doctors and public patients who have an interest in temporomandibular joint disorder to ask questions. I'm available to ask questions or to comment on your comments if you'd like, and I'll bring to the attention of all the viewers any comments or questions that arise during the next 30 minutes or so. So today's topic is very, very important. It's very poignant. It's very timely. And it has been timely literally it's been 50 years timely, because earaches are constantly confused with TMD. Earaches and ear infections are constantly confused with TMD, temporomandibular joint disorder, and I'm going to try to sort that out for you today within the next few minutes. It's really not complicated, whether you be a layperson, potential patient, or a physician or a dentist who has an interest in temporomandibular joint disorder. I can tell you it's not complicated, but here's the problem. Let's voice the problem first of all. It's been my experience over the past 50 years dealing with temporomandibular joint problems and patients who have temporomandibular joint disorder. Remember, it's one disorder. It's not multiple disorders. There's multiple symptoms for sure, but it's not multiple disorders. It's one disorder. The disorder is inflammation within the temporomandibular joint. Inflammation within the temporomandibular joint creates directly each and every one of the symptoms associated with temporomandibular joint disorder. And today we're going to just focus on that one symptom of earache. Earache, ear pain, is one of the most common symptoms associated with TMD. That has been my experience. I think any physician, health practitioner who sees these patients will tell you that frequently patients complain of ear pain, ear aches, when the problem is temporomandibular joint disorder, inflammation within the joint. Here's the problem. If a patient, and this is what I've seen for 50 years, if a patient goes into a walk-in clinic, a convenient care clinic, because that's where they usually go if they have an earache which will not go away. They're usually not going to be able to get an appointment with their PCP. They don't think it's serious enough to go to the emergency department, although some of them do, of which usually the same occurrence happens, which I'm going to explain to you. But most of the time, they will present themselves to a convenient care clinic with a continuous or severe earache. At which point, what will happen is that the nurse practitioner or physician assistant who is manning that convenient care clinic will take an otoscope, look in the ear, and then give the patient a prescription for antibiotic. I don't know exactly what that physician assistant nurse practitioner is looking at, but I can tell you that if you go to a convenient care clinic with an earache, you will 100% of the time walk out with a prescription for antibiotic, usually amoxicillin, penicillin, unless you're allergic to penicillin. Then the patient goes home and takes, usually the prescription is usually a 3-day continuation, 1 tablet every 6 hours for 3 days is the usual prescription description. And the earache continues. And one of two things will happen. Either they will go back to the convenient care clinic and tell the provider that the earache continues to happen. And number one, they will get an additional prescription for antibiotic, or they will get a referral to an otolaryngologist, ear, nose, and throat doctor, who is more skilled at diagnosing earaches. If they get a second prescription for antibiotic, they may end up with a continuous pain, and the pain doesn't go away. If they go to the ENT doctor, either the doctor themselves or the physician assistant for that otolaryngologist will be able to actually see that there is nothing wrong inside the ear. They look at the tympanic membrane, they do not see any evidence of infection, and they tell the patient, I don't see any infection in your ear. You don't have an ear infection, even though you've taken 3 to 6 days of antibiotic. At which, one of two things will happen. Either they will do a very extensive, expensive workup, usually including an MRI, and probably draw some blood and do some multiple additional studies, and patient will end up with a bill of several $1,000s, or the ENT doctor will say, I don't see any infection here. I don't see any reason why you should be having an earache. I believe that you might have temporomandibular joint problems, at which point in 2026, unless that ENT doctor is from Middle Tennessee, that ENT doctor will say, you need to go see your dentist if he thinks it's a TMD problem. You need to go see your dentist. And we've discussed many times how the dentists don't have the information on how to diagnose and solve the TMD problem, how to get rid of that inflammation within the joint. Of course, here in Middle Tennessee, a good number, but not all, but a good number of the otolaryngology practices, ENT practices, are well familiar with doing the examination, opening the jaw, pushing in the glenoid fossa, having the patient bite tightly, and if it hurts, there's your diagnosis. They have the symptom, and they have pain within the temporomandibular joint. There's inflammation in the joint. That proves that there's inflammation. What this mechanism, when you do this, and close rapidly with the fingers in the glenoid fossa, as you open widely and then close rapidly, proves that the joint's inflamed, which is the definition of temporomandibular joint disorder. At which point, if you're not in Middle Tennessee, you're likely to go back to your dentist, who will do one of two things. 50% of the dentists in the United States of America make a night guard, which is a mechanism, a device for protecting the surfaces of the teeth. Does a good job of that. Actually, you cannot crack your teeth, you can't damage your teeth when you have a night guard in place. It's kind of like the equivalent of an athletic or a football mouth guard, much smaller, but does the same thing. And the other 49% of the dentists in the United States say, I don't treat TMD. It's too complicated. It's too complicated. I was told in dental school that nobody knows anything about it. It has a complicated name. It's too complicated. I don't treat that. And then you have really less than 1%, probably more like 1/10 of 1% of the dentists in the United States who try to treat symptoms with various things, like Botox or dry needling or different kind of drug medications, suppressing the nervous system with medication, which is only temporary, if at best. And that is the problem. That is the problem. And this has been going on for 50 years. This is not new. And it doesn't seem to be changing much, except here in Middle Tennessee, where actually I discovered how each and every one of the symptoms associated with temporomandibular joint disorder is created directly by inflammation in the joint. And in a minute, we're going to talk about how that happens, how that is created to create earaches. But it is a major difficulty throughout the United States. We also have doctors now in 20 states who use our same technology, which is quite simple. This technology is so simple. If you have a damaged joint, as the orthopedic surgeons know, if you have a damaged joint, the first thing you want to do is unload the joint. If you unload a damaged joint, you decrease inflammation in the joint. And if you unload the joint, the pain goes away. So if you have a damaged knee that the patient doesn't want to have surgery for, the orthopedic surgeon is going to give the patient a set of crutches and say, get on these crutches, I promise your knee pain is going to go away. Or if you have a damaged elbow, lateral epicondyle, too much tennis elbow, the orthopedic surgeons will put the patient in a sling. And it works very well. Well, that is what a device does that separates the posterior teeth. If you separate the posterior teeth according to a protocol, not any old way you want, you have to have some guidance. You have to know why and how to do it. But if you separate the teeth by the protocol 24/7 for 2 months, nighttime only, the rest of your life, with a device you can speak with, you just can't chew with it. All you're doing is separating the posterior teeth for an appropriate period of time. That unloads the joint. But the point of today's discussion is how in the heck does chronic inflammation within the temporomandibular joint create earaches? So we're going to explain that to you. Let me pull up a diagram. I hope you can see this. It's very direct, and I got this made by AI this morning. A very, very competent AI was able to take the actual information that has been known anatomically for decades. It isn't my information. I didn't create this information. I just quoted to AI exactly what is in the literature, and AI actually within a matter of about 2 minutes produced this diagram. So hopefully you can see on screen what is the temporomandibular joint. For the public online, you can see the ball, which is called the condyle, sitting in the glenoid fossa, which is the socket, and the meniscus or cushion, which sits in between, articular disc. But the point is there are actually three mechanisms that allow chronic inflammation within this joint to get into the external auditory canal. This is literally a cross-section on the side of the skull, through the joint, through the external auditory canal. The joint is immediately in front of the external auditory canal. That's the bony part, the bony feature before you get into the tympanic membrane, the middle ear. So the external auditory canal is right behind the temporomandibular joint, and there is a thin, usually no more than 1 millimeter, sometimes less, of bone that separates these two structures. So what occurs is when a joint gets damaged, when the temporomandibular joint gets damaged, in the three categories that can damage the temporomandibular joint, and there are only three. The first is well known, everyone talks about it, everyone thinks it's the only cause, but it is not. It's only one of three. But clenching and grinding, we call that bruxism, and clenching and grinding of the teeth over a period of time will overload this joint just like you overload a knee with athletic events or extra jogging, too much jogging for years, or tennis elbow. If you overload a joint, it damages the joint. The joint then becomes inflamed as an attempt to heal. Inflammation is nothing more than the body's attempt to heal damage. And if the joint does not heal as expected, then that turns into chronic inflammation over a long period of time. And it's chronic inflammation that has certain biochemicals, cellular exudates, that then can get through this bony, we call it the tympanic plate, through this tympanic plate and into the external auditory canal. So what occurs is quite simple. There are three mechanisms that allow chronic inflammation to get through this bony plate one way or another. The first is there is a certain percent of individuals this bony plate does not fully close after birth and as you grow, and that there's actually a hole through this bony plate that allows cellular exudates to go through the bony plate and stimulate the inside surface of the external auditory canal. And the surfaces of all these bones have what we call periosteum covering them. That's the periosteum, the covering of the bone. And in the periosteum are where the receptors for pain exist. We call those nociceptors, and the nociceptors are stimulated when the cellular exudate fluid stimulates the nociceptors, and the patient will say, I have an earache. It feels like deep ear pain within my ear. The second mechanism is through what we call the canalicular apparatus. They're literally highways through the bone. They're called canaliculi, and highways through the bone that, even though it is closed, fluid can penetrate both the surfaces on the inside of the joint through the bone and get cellular exudates through that system, again, on the inside of the opposite side of the bone, stimulating the nociceptors, and the patients will complain of earache, ear pain. But there's no evidence of infection. There's no swelling that you can see. There's no changes within the external auditory canal. That's why when you look into this ear with the symptom of earache, the doctor, nurse practitioner, will not see anything significant. And then the third mechanism is through the petrotympanic fissure, which is an actual fissure that enters the bone from the distal or back aspect of the temporomandibular joint, and actually can allow cellular fluid into the middle ear, but it can also traverse this bony plate and allow fluid to get into the inside of the external auditory canal, stimulating those nociceptors. So there are actually three separate routes, three separate mechanisms that can occur that allow chronic inflammation and the cellular exudates of chronic inflammation to get through this bony plate and stimulate the pain receptors of the external auditory canal. And as far as the patient is concerned, all that they can say is, I have an earache. My ear hurts. And of course, then they go to the walk-in clinic, and the nurse practitioner, physician's assistant is not schooled well enough to determine whether or not the ear is actually infected, and they walk out with a prescription for antibiotic. Again, as I said, if you go to a convenient care clinic with a symptom of earache, I promise you, you might have an ear infection, at which point then the antibiotic will work really well. If you have an ear infection, 3 days of antibiotic will really do the job, and that will really solve the problem. But if you go to a walk-in clinic and it is not recognized that it is not an ear infection, there's no evidence of infection within the ear, the right thing to do is to think about, maybe this is temporomandibular joint problems. The right thing to do is to do this little maneuver. I'll repeat myself. It's very simple. All you have to do is open widely. Your fingers will go right into where the ball part used to be. You can feel the depression underneath your fingers. Push firmly and close rapidly. When you close rapidly, just once, and you have pressed firmly into that joint space, it'll elicit pain if you have inflammation within the joint. It'll hurt, at which point you've made the diagnosis, temporomandibular joint disorder. You've confirmed that there's inflammation within that joint. And the proper diagnosis term for temporomandibular joint disorder is inflammation within the joint. Simple as that. So that explains, I think, pretty well, with the help of AI and a really nice diagram, how inflammation within the temporomandibular joint, better known to the doctors as TMD, better known to patients and public as TMJ. Of course, everybody has two TMJs, temporomandibular joints, but for the past 70 years, everyone just calls it TMJ, the name of the joint. Kind of indicates the general level of knowledge out there about this problem, and that's what we're trying to solve here on TMD Demystified. The word needs to get out. The awareness needs to get out that this is not a complicated problem. It is a misunderstood problem. It is a misdiagnosed problem for sure. It is a misdirected problem for sure. I don't think anyone does it intentionally. So it's really just a matter of education. It's a matter of bringing up awareness so that they are aware how to diagnose it correctly with the symptoms and pain within the joint. You've made the diagnosis. By the way, the other symptoms which are directly created by inflammation within the temporomandibular joint are frequent and or recurring, that is, frequent and or recurring headaches. We talked about earaches, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, feeling of fullness in the ears, like you've been swimming and can't clear your ear when you've not been swimming, dizziness/vertigo. The definition between those two are slightly different, but basically a feeling of dizziness. Upper back and shoulder pain and tightness, which is extremely common. Arm, hand, finger tingling and numbness, especially tingling and numbness of the last two fingers is the most common kind, but any kind of arm, hand, or finger tingling or numbness, and various kinds of jaw locking. Each and every one of those is directly created by inflammation within the temporomandibular joint. And to finish my thought process, the other two causes for joint damage are acute trauma, athletic accidents, motor vehicle accidents, and the third is functional malocclusion. Bad bites, bites that are so off position, bad position, malocclusion, that it overloads the joint. What all three of those things have in common: bruxism, acute trauma, functional malocclusion, they overload the joint. When you overload a joint, it becomes damaged. The damaged joint creates inflammation. When the inflammation doesn't go on to heal like it should, then you create chronic inflammation, and chronic inflammation creates all those problems. And today we've discussed how chronic inflammation literally creates the feeling, the sensation of earache. All right, I've been watching the live stream viewer counter, and I see we have one viewer on board here. I don't know whether there's any chats involved. If he has a question or comment, I'd be happy to talk about it. Otherwise, I hope that you return for our next episode, but I need to remind the public, the viewers, that next week I will be traveling. I will be at a medical meeting, and I will not be doing a live stream next Saturday, which I think will be then the 18th. The 18th will not have a live stream. The next one will be a week after that. So if you have any other questions or comments, please don't hesitate to voice them. I can always be reached personally at my email at tony@tmjservices.net. And so until next time, I look forward to you coming back and listening to more about TMD Demystified. Until then, have a great week.